Let's try that again. Good afternoon, everyone. Okay. Welcome to the closing plenary. As Doug said, I'm John O'Quick. Since my first CCIH conference a decade ago, I've been the token Christian leader of a secular organization. But as Doug mentioned, I've now graduated from that. So the theme of the 3 days here has been called to care, a strong community for lasting health. And it's really been a rich 3 days. The theme was reinforced by the devotionals, and I really appreciated the way the devotionals happened this year. And I wanted to, and it was based, as we all know, on Philippians 2, which some biblical scholars and people refer to as the book of joy. It's actually my favorite book, so I'm glad that we did that. And I'd like to start with the full, we've focused on 3 and 4. I'd like to start with the first, all 4 of the first verses. If you have any encouragement from being united in Christ, if any comfort from his love, if any fellowship with the Spirit, if any tenderness and compassion, then make my joy complete by being like-minded, having the same love, being one in spirit and purpose. Do nothing out of selfish ambition or vain conceit, but in humility consider others better than yourselves. Each of you should look not only to your own interest, but also to the interest of others, the community. So the 3 devotionals were on the posture of caring, humility, which, as we heard from one of our panelists here, was important to her. The next day, walking in faith, caring for self. And today, the theme's been living out our faith, caring for others. That's a big responsibility. And the first CCIH conference in 2008, I gave a talk. It was the first of what became a series of talks on biblical wisdom for global health. And the theme of that one was lessons from God's first century leadership team. The short story is that leadership team launched the most successful, had a wonderful miracle-working storytelling leader and visionary, and launched the most successful enterprise, international enterprise in human history. One of the things, I looked back at the notes because we were talking about leadership in global health, and Ray Martin helped create a time series. So in the year 2000, think about CCIH. It was 60 individual members, 20 organizational members, and 26 people at the annual meeting. So we now have 150 members, close to 200 people at this conference from 24 different countries. And so I want to, before we get on to it, I want to pause and just, I think it's stunning what's been created, and just say a word of thanks to Ray Martin, to Doug as the bearer of the baton now, and Ann Peterson as heading up the board, Mona, Kathy, all of the rest of the staff and the board of CCIH. I think it would be good as the assembled membership to give them a hearty thank you. So global health, the theme for this session is global health and diplomacy, FBOs on the front lines and at the table. And we're really fortunate to have 2 very accomplished and distinguished panelists. On my far left, Jimmy Kolker. He's had a long career as a diplomat and retired in 2017 as Assistant Secretary for Global Affairs. He was the Chief Health Diplomat at the time that he retired, and has been involved in representing the U.S. government at the World Health Organization, and as an alternate on the board for the Global Fund to fight AIDS, TB, and malaria. He was 30 years a diplomat. He was an ambassador in in Uganda right at the buildup of PEPFAR from 2002 to 2005. A little bit of an aside, while he was there, he and his family happened to be extras in The Last King of Scotland, the story of Idi Amin. I promised not to tell that, but I couldn't help it when the ambassador thing came up. We'll hear more about how he helped the different organizations through that at the time of PEPFAR. He's also served in Burkina Faso, and right when in 2005 and 2007, when PEPFAR was scaling up, he really had a major role in the implementation from the Office of the Global AIDS Coordinator. He's also served at UNICEF in their AIDS division and on several boards and university and some think tanks. I don't think I need to say much about, but I will. Karen Sichinga, who yesterday was awarded the Christian International Health Champion Award. She's executive director of the Churches Health Association in Zambia. And I think, as you heard yesterday, they've got 30%, they provide 30% of the Churches Association, 30% of the health care throughout Zambia, and 50% in rural areas. They have an unbroken record of properly managing Global Fund grants, and really a great reputation. Has training from universities in Canada and the UK, and also serves on some boards, and also she's on the ecumenical HIV and AIDS strategy group for the World Council of Churches. So let's welcome both Jimmy and Karen. So we're gonna look at three questions today related to health diplomacy. Themes and trends in global public health relevant to faith-based organizations, FBOs at the front lines, opportunities and operations. That's a lot of what we've been talking about in the last few days. And FBOs at the table, how to be there, why to be there, and how to be there. That we may have talked less about, but that's something that's really important in an increasingly complex and unchurched world. So looking first at the themes and trends, Ambassador Jimmy Kolker, could you share your perspectives on the recent trends and their relevance to faith-based organizations?
Sure. Thanks, Jono, and thanks to CCIH for inviting me. It's really a treat to be here. And I do think, is it on?
It may be.
There's a green light. Maybe
it's a directional mic.
I'll try to be multi-directional. I do think there's a new paradigm that when I started in the Foreign Service back in the 1970s, so I served 5 posts in Africa, and the model was that organizations or governments from developed countries provided primary services in developing countries. There was a donor-recipient relationship. Research topics were determined by the US-based or northern-based donor, and sometimes they would find African or other third world partners for that research. But this was a very 20th century concept of there were donor countries and organizations, and there were recipients or beneficiaries. That, in my view, has entirely changed. For one thing, the human capacity in low and middle income countries is now able to provide those services because people are graduates from the same universities, they know each other, there's a high level of competence in almost every country in the world. They do not need people from the US or other countries to be providing basic services. And at the same time, the research institutions there, the platform for determining what the country's needs are and how that malaria or AIDS, TB program should go, there's a lot of expertise even at the academic and among professional organizations. And the disease burden is changing. In most low and middle income countries now, the majority of people are dying from non-communicable diseases, not from the traditional infectious diseases. And at the same time, there's a strong emphasis on national ownership. And for faith-based organizations, this has a plus and a minus side, because national ownership in many countries means government ownership of the health response. And so this question of who's at the table and how we organize ourselves is one we'll get to. But at the same time, in addition to non-communicable diseases, on everyone's agenda now has to be surveillance and detection, outbreak response, the health security matters, integration, and I know you've had a whole session on health system strengthening, but how are we trying to integrate what had been siloed programs, often based on donor requirements, into a cohesive system that's patient-centered? And then use of community health workers, use of better referral systems in which you really do need an integrated network. And so I think the bottom line is that low and middle income countries do need and want partners from the US and from the developed world, but those partners have to really have a technical expertise. These can't be people who are just out of school who are looking for a first job, but people who in our own societies are solving these problems and able to give a perspective, whether that perspective is how to manage a grant or how to be accountable for patient records, or whether the perspective is that we're actually providing a higher level of care with greater survival rates, that those partnerships have to be reaching that level of really providing a technical partner, and then assuming that the implementation and the basic services are going to be provided by the in-country partner.
So before you pass on the mic, so you said the 20th century model is outdated. Has everyone moved to the 21st century model?
Well, no, I don't think, for instance, that USAID's system of grant making has moved to the 21st century model. And we'll get to that as well. I think that there are real issues that, I was an ambassador. You submit a need, you see a need for a health response. That goes to USAID. A year later, they will put out a request for proposals. The contractors will give a log frame of what they're going to achieve. They get the grant, they're held to that log frame, they come with an action plan. The first thing is always, well, let's do a needs assessment. Well, there are tons of needs assessments on the shelf. And so let's figure out, and if it was a real emergency, the problem would have been solved. Someone else would be addressing it. And so the idea that 2 years later you're going to have a US-based NGO address a need that we identified a long time ago, I think is part of the old paradigm. USAID is changing. I give them full credit for that. More locally based partners and so on. But it also means that the relationship between the US-based or the international partner and the local partners also has to change. It has to be much more adept, much more recognizing the advantages of what's already being done in country. And I know we'll talk more about that.
Okay. So Karen, at the country level, would you add some trends to that, and what have been the biggest trends that have been affecting Zambia and the members of CHAOS?
Yeah, thank you very much. It is really
no, it's on.
it is really a pleasure to be sharing a podium with Ambassador. I think the trends are much the same. What he describes is very true. I think for me, I take note of what he said. The last thing that he has said is that I think it is taking most of our donor countries to adapt and to realize that things at country level have changed, and that also capacities at country level have been developed, and that even the partners abroad, the donor countries, need to recognize that countries have moved on and they have the capacity and the capabilities of the nationals to carry on these programs.
So, and let me ask you, the trends that we've touched on the trend in terms of the expertise, so the educational trend in a sense, with the economic trend where most countries, the economies are going up. When that happens, people spend more on health, and now there's the universal health coverage movement. And the epidemiology has changed. So we've got we're still trying to deal with the infectious disease epidemic, infectious disease challenge that's coming back, and then chronic diseases. So the epidemiology is sort of the third E. And then in terms of empowerment, I have a sense that governments are a little bit more willing to put donors back on the plane if they don't agree than they were maybe 10 years ago. Could you each talk a little bit about some of those trends in the financing and the sort of environment that NGOs are working in right now in faith-based groups?
Okay, well, I'll start from a government perspective. In 2002, 2005, I was in Uganda. It was the showpiece of PEPFAR. We had lots of programs. Lots of things could have gone wrong. Most of them didn't, and I think we can all be very proud as Americans and people in partner countries that we really have made enormous progress through the PEPFAR program. But I went back to Uganda with a congressional group led by Senator Isaacson in 2012. And we visited 7 or 8, actually, of our PEPFAR partners that had been from my time, all of which, when I left Uganda, were headed by expatriates. When we went back in 2012, not a single one was headed by an expat. There were Ugandans running all of those programs. That, to me, is not only success, but true sustainability. Here were people, there was a national capacity to run the programs, which had been set up, in my view, well set up and achieving results, but that the evolution is that, of course, these should be run by Ugandans. I mean, this is their responsibility, as well as now this critical mass of people who really are good at what they do, and they don't require air flights and housing allowances and education allowances and shipments of cars and containers and so on. And from the point of view of just the costs of the program, there are a lot of advantages, as well as having people who speak languages, who know parenting customs, who know lots more than maybe an expat coming in with the technical knowledge would have.
Yeah.
Thank you very much. Yes, a lot has changed, but I think a lot more needs to change. We still have today, international organizations, and so, for example, the CHA membership. For example, for CHAs, you still have international organizations that would be working for an international NGO, and they're paid better. And so what you do, you see is an exodus of those very capable and very specialized health workers or even public health specialists who would now move from a local NGO to an expatriate NGO where the pay is better. They're still in country, but in comparison, the pay is much better when you move from a local organization to an international organization. And while that is good, it's still not sustainable.
And when you think about the trend, are things the way you describe it, it sounds like it's sort of as it's been. Do you see any bright lights on the horizon?
What is happening at country level is very interesting. The dynamics are changing, but by and large, it's the same thing. It's the same principle. What is happening is we see international organizations that are registering as local, and they are local so that they can be registered at country level, but you still have the governing, the body, the powers are still abroad and calling the shots. Even though they have employed the local people, the powers are still invested elsewhere. And it's only local because they're employing local people. But in terms of decision making, these NGOs, the powers are still invested elsewhere.
So let's flag that whole dynamic as an issue when we come back to the question, or come to the question of being at the table, and what are the ways that faith-based organizations can be engaged in trying to change some of the dynamics there. Let's shift for a minute back to some of the trends. And how is the work of groups like your members in CHAZ affected by the changing epidemiology and the overall Zambian economy in terms of?
Yeah, it's a big challenge. First of all, historically, the Christian health hospitals, 2 decades ago, or even just a decade ago, by and large, you had expatriate doctors coming from abroad and beefing up human resource at those facilities. We had experts. We still have some that will come maybe during the summer holidays to help us beef up surgery or any specialized care. But we have seen that it's dwindling now. So we no longer have experts that would come to beef up health workers and expertise in those mission hospitals. And what we also have to remember, even for the nationals who are maybe, in our case, young Zambian doctors who would have been just trained or just came out of medical school 10 years ago, they would have gone to the rural areas, saved maybe for 2 years, but because you don't have enough amenities in the rural areas, they tend to move back, and some of them are poached by international programs. And, if they would stay within the country and work within the country, it's okay. But most of them would have left the country and still going somewhere looking for greener pastures. It's still happening today because our rural areas are not as the same as in Lusaka. So the amenities in Lusaka are not the same as way back, way in Northern Province. And while your young doctors, when they graduate, or young nurses, they'll be in the rural areas, but when they're about to get married or after they get married, they still want to move back. And also the likelihood of being promoted, most of them feel like they're neglected when they're out there. So the likelihood of being promoted when they're serving in the rural areas, and that's where most hospitals, church hospitals are, is very slim. So they tend to move back to town where they have greater chances of advancing their careers and also sending their children to better schools.
So with it, you've done really well with grants from the Global Fund.
Yes.
And what impact has that had, and how is how's the prospect look going forward on that?
I think, I want to be. We've done well because we have partnerships and we have people that support us. We've done well because of two things at CHAS. We wanted to employ competent people that would stay and work. We also have done well in the sense it's stewardship, making sure you remain accountable for the funds that are given to the organization. And we don't want to say that we've done it alone. We have had a lot of support from church leaders, from our facility in terms of accountability, but we've also have been very hard on some of the facilities because we have had to embrace other sub-recipients that are not necessarily from the FBO family. And so we have had to be very, very strict. We have had to ask for people to pay back. And so you do not remain very popular in country when you do that kind of thing. We also have had sometimes international organizations fighting us because we are local and indigenous. And you still have sometimes people who look down on you because you are local. Our staff is completely Zambian. And so sometimes they look at you and they think that you do not have the capacity. But we have been with the Global Fund since its inception. And there was a time that Zambia had, really had bad news in terms, but we were the only principal recipients that, were not found wanting. And so we've remained a principal recipient. But we do have sometimes international NGOs that are fighting us to get out of the playing field. It's a fight. It is a struggle to continue being a principal recipient. But we have had the support of government as recognizing that CHAS has been the only organization that has been accountable. And we have performed A+ and A's, occasionally B's. So we continue. I think also it's by the grace of God. We have, being a principal of recipients of the Global Fund and being a local NGOs that has never fallen out of being a principal recipient has also created a lot of enemies. Sometimes amongst the international NGOs, they doubt our capacity because they don't see anybody at the Secretariat who's not Zambian. And so they're always querying the capacity. How have you continued to manage the Global Fund for 16 years? But it is, I think, with a prayer and seeking God's guidance and also strength. It hasn't been easy.
Well, So let me ask you, what advice would you give to other Christian Health Association leaders and folks that work with Christian health associations? I'm just thinking, we had an interesting exercise several years ago at MSH because we said, let's work with the Christian Health Association of Nigeria. And so we proposed to be the principal recipient, of course, as big groups always do. And USAID said, no, we would prefer that the Chan is principal recipient. We said, that's fine. And then the USAID went through their due diligence, and they said, well, actually, we've looked at the book. We'd prefer that you be the principal recipient. And finally, at the end, Chan was the principal recipient, and we were an advisor, and it was actually a good partnership. I mean, they anybody here from Nigeria? Is Chan? Okay. Okay, well, you know, Chan is the only health institution in Nigeria that has operating health facilities at every state. Because, you know, health is mostly a state matter. But so back to the question, I mean, how would you advise those of us who work with Christian health associations or who are in Christian health associations in the different countries, what is the key to being able to play the sort of role that you played, despite the skepticism and despite the sort of not recognizing that the folks in the country are just as smart and very often just as educated. And so, you know, how do you deal with that? I mean, what advice would you give?
You know, I have a lot of confidence in all the Christian health associations that are here and those who couldn't attend. But usually it is just a politics at country level. They all have the capacity. Zimbabwe has the capacity, Ghana has the capacity, Uganda has the capacity. All our Christian health associations have the capacity. But what is at play at country level, it is usually the politics. The politics, I wouldn't sit here and say we have overcome. Every year, every funding cycle, every 3 years is politics. We have NGOs that align with international NGOs and they want to remove CHARS from being a principal recipient. And they would come up with so many flimsy ideas that we are not saving the marginalized population, we're not doing this. And they would say, okay, give us the statistics, because and define who's marginalized in our setting, because everybody is marginalized where I come from. Everybody is living below the poverty line. Everybody is marginalized. But they will say key population. We say, okay, define what is people. Defining key population is subjective. It's subjective. It is each country, in my opinion, needs to define what is key population. We cannot all just get the global definition of key population. I would rather we define what is key population in Zambia. This putting a blanket on key population is not fair, because our key population in Zambia is not a key population in America. My key population is the under 5 and the woman. The woman who's in labor and cannot get to the health facilities because she would have to travel 50 miles. That's the key population for me. Okay? So it can't, I mean, somehow this global health has this global view of just defining and making sure every country adopts what is key population. My take home and my message to the power that are today, where they're here or they're in England, key population needs to be defined by the country. We have key population. We have under 5 children that are dying because of hunger. That is a key population. I have a woman who's dying in labor, can't make it to the clinic because there's no transport, so far away. That's my key population. So a key population cannot be a blanket. Hell no. So we need to have a definition. Each country needs to come up with a key population. And this is what is hindering universal health coverage, because there's a universal definition of populations. It shouldn't be the case. Each country needs to come up with a key population. Jimmy,
do you want to come in? And then I've got to...
Sure.
Yeah.
Well, I was going to say, when I I knew very little about AIDS. I never took a science course in college. I had to learn science as a second language, but to run the biggest AIDS program in the world. And as ambassador to Uganda, I had to press the send button on this country operating plan that was that doubled every year. I mean, $120 million of money for AIDS, and pretty much in 2003 and 4, if you were in global AIDS business, you had to be in Uganda, and you wanted to get into the country operating plan in Uganda. And so, they came to see me, and I wanted to meet them. And the questions I'd ask to organizations is, first, how does what you do fit into the national plan? And that, I think, reinforces what you say, that this has to be a nationally owned response. On the other hand, most national plans denied that there were women selling sex, denied that there were men having sex with men, denied that there were drug users. And if those key populations aren't engaged in the national plan, it doesn't mean every organization has to specialize in those groups, but it did mean that you probably wanted to look at, were they getting services somewhere? So that I don't think we disagree about key populations, but I do think that looking at the international definition and looking is the national plan covering those people who are at risk probably is important in things like AIDS, but also Ebola, the very most rural populations who are eating game meat or playing with bats or other things. So that was the first question. How does what you do fit in the national plan? Second question.
So this is the questions. When you were reviewing the plan before pushing the send button in Washington, number one was is it in the internet? Is it in the
Uganda
national
plan?
Okay.
So consistent with.
Yeah.
Because we weren't giving money in those days to the government of Uganda.
Yeah.
And for a lot of reasons which I think were valid at the time. And the second question was, what results do you expect to see in 2 years? This had to be not just an awareness-raising program, but something that was going to accomplish something. But the third and most important question was, who in Uganda is already doing what you want to do, and how are you going to add value to what they're doing? And I think so many of our organizations, both domestic but especially international organizations, have an expertise. You have a program, it works somewhere, you know how to do it, that's what you're expert on, you're good at it. Gosh, it's worked, and you know it would work in Uganda. But the question is, there probably is someone who's already thought of this. And unless you take account of who's already doing this, what space they have, and what they need to bring this program across the finish line, you're not going to be adding value to the program, even in the area where you're expert. And so it does seem to me that that's an important question for the Global Fund and for others, is who's already doing this? And as you have to put in the national request to the Global Fund. And if they aren't covering all of those bases and looking at what are we doing domestically, what do we need extra money for, what would we need to pay extra partners to help us achieve, that you're probably not going to succeed in using that money to best advantage.
Karen.
Thank you, Ambassador. What I wanted to say is that normally, I think at country level, for the partner organization, our sister organization in this country, CHAG, CHAN, ZACH, CHAM, the Uganda Protestant Bureau and the Catholic Bureaus, and Kenya, CHAC, they have the capacity. They have the capacity, and I think the message I'd like to send home, these organizations are not going anywhere. Okay, so we'll do very well to make sure that we continue building capacity, because they're not going anywhere. First of all, their governments respect them. So it will do well for our partners who come with resources, because resources we need. So it will do well for our partners, instead of setting their own NGOs, to look at these capacities. Because their government respect CHAM, CHAN, ZACH. So it would be nice for us to work through those already existing structures. That's what would be my send-home message.
Good. Well, then that takes us to this question of being at the table, because the table is where decisions get made. So what we're talking about is stakeholder meetings, networks, where they're talking about policy issues, financing issues, operational issues, technical issues. And so three questions, which maybe we can try to do them one at a time. Which are the most important tables for FBOs to be at? And actually, the second is what's the objective being there, and the third is how do we get there. So let's start with which are the most important tables, and let's start with Karen. At the national level, to influence the decisions and address some of the concerns and bring everyone into the 21st century, what are the tables that you as Chaz need to be at and are at?
Okay, yes, maybe the latter one is which tables are we at? And I think we're at all the tables. Sometimes, as FBOs, we are very humble and unnecessarily humble. That kind of humbleness, sometimes we will not be invited, but we will go.
And can you? All right.
We will not be, as Chaz Zambia, we will hear of...
Can you give us an example?
I'll give you an example,
Okay.
and a very fresh example.
Okay.
We share notes. We share notes with CHAC, Kenya. We share notes with ZACH. We share notes with CHAM. And from CHAC and ZACH, I got to hear that the PEPFAR program, they are on the table. And I wondered why Chaz we were on the table. And they were, they had called a meeting. And we had not been invited. And I sent two of my heads of department from the grants and compliance, head of grant and compliance and health programs. I said, there's a PEPFAR meeting, and we are not on the table for some reason. And we need to be on the table. We need to know how they are selecting who's going to implement this 100 million that is targeting FBOs. Because we had shared notes. We share notes among ourselves. I heard from V, I heard from Mwenda, I heard from, Malawi. And I'm like, so why are we not on the table? But it dawned to me that in Zambia, it's like, and I'll say this for what it is worth. Because we are on the Global Fund, and with an unbroken record for the 16, 18 years. So you begin to see how others begin to shun you. And of no fault of your own. And you have gaps, because Global Fund will not be able to address all the gaps. But for some reason, they begin to shun you. And that's what was going through my head. So when I heard that there was a PEPFAR meeting, and it was one of those that they need to decide who you want to be implementing, and I'd heard from CHAC, I'd heard from ZACH, I had heard from all my colleagues, And I'm like, but why are we not on the table? So I did, delegate my two heads of department, go and sit in that meeting. We were not invited, but we had to go. So sometimes you are not going to be invited, but you need to be proactive, because you can't look at your interest. You have to look at the marginalized communities that you are saving in rural Zambia. And it's the same thing for my colleagues here. We're not saving people who are in, Harare alone, or Nairobi, or Lilongwe, we are saving people who are in the villages, communities where even government facilities are non-existent. And so sometimes you are not invited, you do invite yourself. And it's not very comfortable. Yeah, it's not very comfortable, but you have to be there.
And so the two parts to that. One is the intelligence. So one of the things that I'm hearing is the power of the network, the Christian Health Association and faith-based network around Africa to give you that intelligence.
Because if you told me, my friend, are you on this table? I said, I'm not.
Yeah.
So she's like, okay, no.
Okay.
So she's like, watch out. I think this is happening. Yeah.
So let me ask you: do you advise each other and sort of when you have this back and forth, and when you get the word from the Christian Health Association in Kenya or Malawi that this is going on? Do you then say, well, are you going to that meeting? And you're okay, good.
We have this,
That's an important.
information.
So that's great. It's an important part of diplomacy of any kind is intelligence. One of the during AIDS at the World Health at our program at WHO, we used to do things that would really upset the U.S. government, like set up a generic pre-qualification system and try to educate ministers of health on the trade agreements. And one thing, Jimmy, I'll tell you this now. There are two things were predictable. One is that the U.S. would send out what they call a démarche, which is like a heavy-duty, quasi-secret communication, diplomatic communication. And so we get a call back from the Ministry of Health in Kenya and say, the Ministry of Foreign Affairs is talking about this trade thing and all. What's this about? So we got great promotion for the issues that we were dealing with. And we also, we got better at that because we knew we'd have to make things bulletproof. So intelligence is really important. And the network. So any other things about how the faith-based community sort of can empower each other?
I think we have through ACHAP, where we are learning from each other, and that's a wonderful way. We're learning from each other. We have in ACHAP we have identified, and the ACHAP chair is here. Peter, and we learn from each other. We know our strength within the network. I know that if I go to Ghana, I'll learn because Zambia is going to be implementing the national health insurance. I know that I can call Peter and say, so how has it worked? And I know because I sit on that national insurance board of directors, I'll have to call Peter. How did it work? How is it working right now? So I think we do share notes. I can call Zimbabwe anytime. I can call, Kenya anytime and say, what about this? So we do share notes. We do share challenges, and we do share how to get around those challenges.
So one of the tables, we've talked about the table of sort of that donor table. What are the other tables still in the country that faith-based organizations need to be at?
I think right now we are talking about the PEPFAR funding. In some, I don't know, I think Kenya, they are more advanced. I understand that's why Samuel is not here. But in some of our countries, they're still discussing and identifying which FBOs are going to be on the table. And sometimes our experience is that, to my colleagues, so if you are deemed to be successful, sometimes for some of the funding, that's the more reason they will leave you out of that table. For some reason, only best known to themselves. And sometimes we are perpetuating this in Zambia because even with this PEPFAR funding, they're not including us on the table. And we don't understand why, because we don't have any issues with anyone. But we don't understand. Yet we are, apart from government network, we are the second largest healthcare provider. And we have a network. We not only have a network, but we also have the capacity to deliver. We have proven over the 18 years with the Global Fund that we can deliver and be accountable. We can be accountable for the funding. But yet on this discussion, the truth of the matter, I had to send my senior staff to go to this meeting. And I'll say it for whatever it is worth. We were not invited on that table. We have heard of the 100 million, but we are not invited on that table.
So let me ask Jimmy, in terms of the country coordinating mechanisms for the Global Fund or World Bank projects or other sort of entities, what are the other things that you've seen at the country level faith-based organizations have a role to play?
Sure, it's a treat to be on the panel with Karen because that perspective is the one that's very hard for bureaucrats to actually wrap our minds around because there are so many structures that make it hard to do. The first is procurement-sensitive discussions. I mean, if a bidder on a potential project knows that the budget is going to be 1.6 million and that this is what we're looking for in terms of implementation, that person who's been in the meetings where that's discussed has an advantage over bidders who haven't been in that meeting. And at various degrees, the U.S. procurement process, and HHS is even more strict about this than state or USAID, that you just can't be in the room. WHO is also very worried about this. WHO being a member state organization deals with governments. And WHO, because it's a member state organization, because they haven't figured out how to deal with faith-based groups, and they certainly haven't figured out how to deal with the private sector, everything is a workaround. I mean, we have UNH, you have the Global Fund, Gavi, Rollback Malaria, Stop TB Partnership, Partnership for Maternal and Neonatal Health, and I could go on. There are 24 groups that are workarounds to enable people to be at the table who aren't member states, mostly NGOs, but also foundations. I mean, Gates is the second biggest funder of the WHO, and they have no role in the governance structure at all. So there are dilemmas that this provides, and I guess I'll just try to list some of them. The country coordinating mechanisms are designed to have all constituencies. They're required to have civil society organizations, required to have people who are HIV positive or been affected by TB and malaria. At the same time, as she said, CHAS is the golden example of a faith-based group that's been a great partner of the Global Fund. But these country coordinating mechanisms, again, are defining what the priorities should be for the country plan that's submitted to the Global Fund. And if you're in the room, you sure have an advantage over people who aren't in the room. And so and all of the principal recipients are there. It's not faith-based groups singled out. But the Ministry of Health has a grotesque conflict of interest because they often chair these groups and are intimately involved in submitting the proposals. So there's a problem with saying, are you at the table or not, if you also want to be a grantee and implement the program. Most, not the US, but most donors in most of the countries where all of you work are sector donors. So there'll be a health sector donor, they're budget support donors. The World Bank works through ministries to budget support for most of their projects. And so there's a public sector-led sector group there. Often because the government has its own facilities, they don't think about faith-based groups as being part of that sector advisory group, which the donors require. But the Nordic countries, the UK, the Irish, often put all their health money into these sector-based programs, which have advisory groups, and faith-based groups aren't always there.
So so part of the thing for faith-based organizations is to get a mapping, an understanding.
Yeah, and they're technical advisory panels for all the diseases, all the silent programs. Those are other tables where you should be.
Yeah.
If often the faith-based organizations, like the one in Kenya, have their own supply chains. There's probably a supply chain working group where they may or may not be at an equal basis with the government system, even if they far outperform them in terms of getting drugs to clinics or hospitals. Health management information systems. Is there a single system that all the facilities are reporting to? And how do you get in the room to be sure that your interests and the interests of your facilities are there? Most of you have encountered these problems every day with the organizations you're working at. But there's not one table. There are like 20 tables, even in smaller countries. And being part of all of them are a result of siloed programs, are a result of donor requirements, but they also, to some extent, are a result of good management, that you don't want everything just to be in one person's office in the Ministry of Health.
So let's take it then up one level to the international level. And what advice about which tables there? There's the World Health Organization is one. There are the trade organizations.
Sure, and wouldn't it be great if there were only one World Health Organization? The regional and country offices have enormous autonomy. They have independent budgets. They have independent donors. And so getting to know the organization, which most of you probably know, but if I had 100 people in the room, I doubt that a single one would know that the World Health Organization for Africa is in Brazzaville, a place that's not on the beaten path for most U.S. NGOs. The country offices, until recently, I give Sidi Moeti, the new Africa head, full credit. She's reversed this practice. But until very recently, the country offices of the Global Fund were staffed by people who got their jobs. WHO. I'm sorry, the WHO, exactly. I apologize. Apologize to the Global Fund. They have no country offices. Partly for that reason. We're staffed by people who supported the regional director's election. Former ministers of health, permanent secretaries in the ministries of health were given sinecures, tripling their salaries from their own governments, which is a further problem. And these people are at the end of their careers. They are politically obliged. They are not public health experts. And these people are embedded in the Ministry of Health, and they see their role as a spigot to turn on WHO money for the ministries of health in the countries and for the public sector. So you need to get at the regional technical advisory level, at the country technical advisory level, to be sure that WHO and UNICEF and the Population Fund and the World Food Program and the World Bank are actually aware of what contribution the faith-based groups are doing, both collectively and individually, and then figure out how do these, again, you can sell the program by saying, here's your plan, this is your strategy, and here's how we're actually going to implement it better than the folks that you think are in the public sector and they're familiar to you because they're your traditional partners. And I add on Ebola, this is a good lesson for all of us because Ebola has redefined a lot of what global health is from the US government side. The Ebola response failed in part at the beginning because we weren't dealing with burial practices. Weren't dealing with things where faith-based groups have a huge comparative advantage over any other kind of public health message. And so the fact that the imams in Guinea and the church leaders in Liberia and Sierra Leone were not at the table from the beginning meant we lost thousands of people because they were the only ones who could get the behavior change that was needed to actually get communities to own the problem and deal with it.
And the success story of getting the faith-based community involved is shown in the epidemic curves. The story that the West has is this big explosion of Ebola. And that's the disaster story. But the success story that doesn't get out is how quickly, look at those curves, how quickly the epidemic, particularly in Sierra Leone, but in other countries.
Particularly in Liberia, where the burial practices and the faith-based role was very clear, and there was a date, and you can just see the curve come down.
So I want to ask Karen one other question, and then open it up to questions from the audience and any comments. I had down that we were supposed to end this session at 3:30, but I'm getting, okay, fine. So we got, good, perfect. Okay. So Karen, anything else you want? At the international level, how do you either influence or get information, and what are you needing, or what are you able to contribute to some of these international debates?
I think the contribution begins from the country level, and I know that most of us, and I've shared with colleagues from different countries on the ICHAP membership, that we do sit at the international level. We are recognized by our governments. We have a voice in country. For example, Charles, we represent all other NGOs on the policy group for the Ministry of Health. So we have a voice. We speak on behalf of all other NGOs. But even that, you still had resistance from non-FBO members. So there are those politics at country level. At international level, we have organizations such as the World Council of Churches, and Mai is here. So we have committees there. There's the HIV strategy group. I do sit on that group. We also have economical pharmaceutical foundation network, and I know V sits as Zimbabwe Zach sits as a board member. We have other global networks that we are represented, but I think the voice could be stronger. The voice, I think, the voice from ourselves is strong enough, but we need others. Particularly with secular organization and the powers that there's still this feeling that FBOs don't have much to offer. Because particularly at the global level, we in my opinion, we are not represented well enough. We are represented at the country level and they recognize our contribution, but at the global level, I think we are shunned. And the stereotype that we are not educated enough or not well informed enough. And the reason sometimes is that we are shy to declare our faith. And even though we may be so educated and have the powers, and I recognize that in some countries you can't easily tell people what your faith, but we don't need to be shy, guys. We don't need to be shy. I need to tell the world that I'm a Christian and I can't sit at the global level and contribute. Because the stereotype is that FBOs or Christian are not educated enough. That is what, because the educated have not come out and said they are educated and they have something to offer.
Wow. Oh, but let me ask: when you're sitting on the ecumenical council, it's the HIV group for
It's
the
HIV
World Council of
Strategy Group,
Churches.
yes.
So, do you see yourself as representing CHAS, as representing all of the Christian health associations in Africa that you're aware of, or representing, in a sense, speaking for the wider kind of global CCIH community? I mean, how do you think of who you're representing when you're on there?
On that strategy group of HIV, the WCC, and the MI is there, I see myself as representing the ACHAP group.
Remind us, ACHAP.
Africa.
Well, just describe it so we're sure what.
The ACHAP, well, the ACHAPs are here. ACHAP.
What?
Let's share.
Just tell us. You don't have to tell us what. But what?
I can describe it.
What is it? What is ACHAP? So people know who's being represented. Maybe you're being represented and don't know it.
Yeah. I can describe it, but because I used to be the chair, but the current chair is that one who can describe it, just to give him a chance to say what ACHAP is, because I can describe it. Yeah, but just to give him an opportunity to say what ACHAP is.
You want to?
You need to use a microphone.
Yeah.
Thank you very much. This is an opportunistic platform.
We set this up at the beginning.
Yeah, thank you very much. So, ACHAP stands for Africa Christian Health Associations Platform. That is a network of Christian health associations and health networks in Africa. Together, we are composed of 41 member organizations located in 32 sub-Saharan African countries. And we provide between 40 to 70% of healthcare totally in sub-Saharan Africa. And we impact about over 500 million, over 500 million population. We have over 5,000 healthcare facilities, and therefore we are indispensable when it comes to health service provision. We are the go-to health service providers. That is
okay.
So, John, before we have questions, can I just give a comment on that? I'm sorry. Before we go to questions, can I just add to that from a bureaucrat's perspective? If diplomats if we're good at our jobs, and some of us are, we're able to put our priorities onto other people's agendas. And if you dissect that phrase a little bit, first, what you're advocating with the policymaker needs to be a priority, and you have to define for yourself. We can't just say, we're here, we've been here for 50 years, we're a wonderful organization, we have a lot of members. What's the priority? What are you actually advocating for? What's your comparative advantage? Then the sense of other people and their agendas. Question is, where are the policymakers coming from? What's their national plan? What have they said about the issue you're discussing? And to get them to own it, to say, this is about your agenda, and here's where we fit on your agenda. And then to the question of the other people, are these people who who want data and evidence? Some leaders do, certainly some bureaucrats. It's very good to give we provide 40% of the healthcare. That's the kind of statistic. Or it could be that, Minister, I know you grew up in Yako, and you know who's providing the healthcare there, and it's our organization, and this is how we fit in. And you remember Dr. So-and-so or the nun that was running the clinic. And so, but think about that. I think you really have to consciously say, how are we going to put our priorities onto someone else's agenda? And that you're talking about an individual or an organization that actually has an agenda. So, thanks.
I'll give you one example of that. The best manager I ever worked with was a Haitian who became the chief operating officer. And the way he worked, if USA said we wanted to go that way, and Paul knew we should go this way, he'd say, yeah, okay, all right, let's keep walking together, Okay? And he eventually got that. It was a very clever way of doing it. Okay, we're open for questions.
Yeah. Since I used USAID's name in vain, it was not Anne.
No, I wouldn't have done anything wrong. I have a question that I have been pondering and concerned about both personally and professionally for a while, and you're exactly the right group. I began my career as a missionary in Kenya, and I loved living and working there. And in 3.5 years, our team was ready to run it themselves. And we turned it over, and I very reluctantly had to leave, but I desired to be able to stay. I would like my children and my children's children to have the opportunity to live and work in other countries. So that's the personal part. When I think of your role, Ambassador Kolker, diplomacy has to do with understanding other cultures and other places. I was on, I can't tell you how many congressional delegations, and you took these guys who were making decisions about policy in the US and money for international development, and many of them didn't have passports. You brought them to see what was going on, and you changed their view of the needs. So there is a need for the North to South engagement in a deep enough way that you can really continue the conversations. So my question, what I hope, is that there is a role for international NGOs, where I am now, and Northern professionals to take sort of the breadth of what we see and the technical expertise and still bring it. But am I fooling myself? Because I just direly want to be able to keep that engagement, and I'm afraid that on both the personal and on the country-to-country level, we could, if we become too independent, get into our silos. We know America is going kind of isolationist. There are great harms to that. How do we retain that professional engagement while still managing to encourage local capacity building, local ownership? And I'm worried about it.
So, okay.
No, please.
Okay. Thank you very much. You know, there's room. And when we're saying that we have the capacity, I think no one organization, no one government has all 100% capacity. We encourage volunteers, we encourage people to come and work with us. We recognize that we don't have it all, and we need the help, but we also want that respect that when you come, you recognize that we have the capacity. We have some capacity, and it's not just from the beginning so when you're there, we want you to recognize the capacity that we have, and you are there to facilitate. And I don't know that we have closed doors. No, we have not. I mean, my colleagues are here from different countries in Africa. We have not closed doors. We need that expertise, but we also need you to recognize that we have some capacity.
When they talked about the new paradigm, there are people who can do most things in most countries now. Doesn't mean they don't want or need partners from the developed world, but look, the bar is higher. What actually can you do? What value can you add to their activities? And it could be grant writing proposals. It could be financial management. It could be behavior change communication efforts. It could be questions about quality of services that are being provided, and how do you judge that? How do you report your results? How do you use modern technologies and so on? These could all be things that can add value to partner organizations for which your children and your organizations that you're all representing, those who are from the US or from developed countries, we're doing this in our countries. And I think one of the questions that you get as an ambassador or representative, when I was Assistant Secretary at HHS, said, well, how do you deal with this problem in the United States? People want to have a world standard. They want to have first world standards everywhere. And if your children or your organizations are dealing with these problems in the United States and are actually at a community health clinic or at a bureaucratic level making decisions about this, that knowledge is actually very valuable in partner countries. What are the dilemmas you face? What are the trade-offs? How do you reimburse providers? Do you use volunteers? Do you keep monthly reports or quarterly reports? Do you have to respond to a citizens advisory group? All of these are questions that all of our organizations deal with all the time. And the question of, we've been through a lot of these in the US, and maybe we're doing well, maybe we're not. But to the idea of how do we do this as Americans, that knowledge is valuable to other people.
Let me also add that there's a reverse transfer that needs to happen. NPR about a year ago had this coverage of a really unique program. I think it was in St. Louis, because they'd seen that people kept coming in and out of the hospital and all, and they figured out that if they had a $15 an hour person who would make home visits, they could keep it saved a fortune. And this innovative program was called Community Health Workers. That's exactly what they called it. Do we have other? So let's. What I'd like to do is try to get a number of folks to get their thoughts up here, and then we can respond. So who's got the mic? Whoever's got the mic out there can lead the. Yeah. Let's take a couple of them. If we get the front here and then maybe the back, and we'll try to do a twofer.
Thank you very much, and I would like to thank the speakers for such an insightful discussion. In these days, we hear about the number of partners talking about sustainability and self-reliance. And as a not-for-profit organization, it sends shivers in some of our spines due to the fact that if you look at most of the faith-based organizations, they are mostly dependent on donor funding and not so much on their own resources. And looking at where we are going now in terms of health delivery, where we're also looking at some diseases which might have resources reduced because they've gone on for a long time. There's a review that we now should focus on NCDs and other things. I just wanted to find out from the ambassador in terms of country development, what does it mean for the future? And then for Ms. Sichinga, how do we then survive in that environment?
Okay, so sustainability, the future, and then one other question from the back, and then we'll work forward.
I'm Kolker from World Council of Churches. I will have a comment on the forum where we should be and making ourselves available and being on the table. I think there's also room for us learning to tell our own story, creating our own forum, and creating our own space and having that confidence that we can convene an international conference on Christian perspective on primary healthcare and present papers and tell the story from our perspective. Invite them to our circles and tell our story. I think there's something we can try to explore and see whether we can actually shift. We can actually shift the narrative instead of waiting to get there and say it and creating a space and say we are going to have this and this is what we're going to present and you are invited to come and listen to and participate. The other point I want to say, which is a bit of a dream I have, someone the experience of Karen, we cannot clone her and send her around the different CHAs that are struggling. And secondly, she did not get where she is in terms of professionally overnight. So there is a way we can say, how can we translate or tap her knowledge and expertise and share it among the different CHAs? And when you are a CHA head, it doesn't mean you are a perfect manager. They are at different levels. They are struggling. They are also learning. They have to learn the job. So at some point I had, if I have to borrow somebody's words, I had a dream that maybe we could have like a training session for CHAs. We run it maybe once every year or once every 2 years. A 1 week or a 2 week seminar for how to run a Christian Health Association. And then we have different modules and we run it, and one who is newly appointed as an executive director, maybe in January, later in the year they come to that conference and they learn, and people with expertise and experience like Karen, they can have that opportunity to share. And so those who are unsure, they are struggling in their countries, they are trying to navigate, that could be a forum to strengthen our leadership, management, vision, and all that.
So that's great. So we got two sides of the coin of sustainability. You want to kick off, Karen?
Okay, I'll ask. My sister V has answered. How do we sustain our services as a Christian Health Association? I'll begin by asking you, my sister, the question: is health sustainable? Okay, we go to the United States of America, one of the role model and a very rich country. We're here today. Is their health services sustainable? Okay, we'll go to Japan, and we'll go to Germany, and we'll go to England. So, you know, what I'm trying to say, we need to unpack it, this word sustainability. What do we mean? Okay? Do we mean the skills? If we're meaning funding, no health system is sustainable. So, as Christian health associations, we existed before the governments of the day in our countries. Okay? We, in Zambia, for example, we had, and in Zimbabwe and Malawi, because we were one country that time. And we need to go back and be one country. We were one country. And our health systems were there, the church health systems were there before our countries became independent. Okay? They've been sustained up to today. There's something there. So when we say sustainable, what do we mean? We need to unpack it. We need to unpack that word. Is it sustainability in terms of the capacity? But quite often what we mean when we say sustainable, we mean money. Okay? And it's always about money, and then we get blocked down in our head. We can't think further because we're just always thinking about money. But we have the human capital. We have so many things that can be sustained. Zimbabwe, Malawi, and Zambia, because we share the umbilical cord, we have the same system. We have our health systems, the church health systems that are intertwined and integrated into the public health system. And our systems are considered public. And I'm not lying, because our health workers are seconded. The health workers are government health workers and working in mission hospitals. If you can't call that sustainable, then what is sustainable? Because they are on government payroll. Okay? That's one thing. So that is sustainability in itself, because we have integrated our health services, because our government at independence decided, no, the mission hospitals are many, more than the government, so we need to integrate them into the system. But we recognize and we make sure that they are still owning them, whether it's 25%, 30%, it's still church-owned 25%. But the health workers, the case of Zambia, the health workers, the running cost at least 75%, the essential medicine all come from government. That is sustainable, my friend. So what we have to make sure is this relationship with government continues going, because they're worried about the people who vote for them. In most cases, the mission hospital is the only hospital, serving about 10,000 people. And there's no other government hospital, but a very old and rugged mission hospital, 100 years old, is still there. And you and I and we know that where there's a mission hospital, even if the government hospital has been built today with very modern facility and equipment, patients will still go to the old rugged mission hospital. That is sustainability.
That's hard to top, and I know we're short on time, but I think that it would be a real mistake for organizations to just run after the money. People are turning attention to non-communicable diseases, to health preparedness, health security, other things. Look at your organization. Are there comparative advantages that you have that would do that. For instance, the hospice movement for the AIDS response. Turned out at the beginning of AIDS, this was chronic care. This was helping people deal with death. And the hospice movement turned out to be a good ally. Once medicines came in, less so. And there may be strengths in your organization that are sustainable or that can adapt, but if you're seen as just running after the money, it's not credible, you won't do a very good job, and I'm not sure that that's what your self-worth is anyway. So listen to your customers. It seems to me the most valuable advice for a health program is that patients themselves know what they need next. People who got on antiretroviral medications needed food. They were hungry. They didn't have jobs. You metabolize more if you were on antiretroviral medicines. And the PEPFAR program couldn't provide nutritional aid. We had to scrounge for partners and try to find others who were able to deal with nutritional issues. So listen to your customers, look at what the situation is, and then, as the gentleman in the back said, tell your story. I think it's important to tell your story at two levels. There are certainly decision makers who want to see the data. How many patients are you treating? What are your outcomes? What's the quality of the services? Are you getting value for money? Would it be a good investment? But the real story that most of your organizations are telling are cute kids and saying this, here are people who, you should care about the people we're helping. And we need to, and that message is equally true now for local donors. There are high net worth individuals, there are cell phone companies, there are fuel companies in every country, in virtually every province of every country, that now see a corporate social responsibility emerging and helping the people that they see in their communities with a need that you've authorized. And you may need to bring in a writer to tell your story. Here is Sarah and her community. What does she need? How did our organization change her life, her family's life, her community's life? And those stories still resonate. Sadly, emergencies resonate more than almost anything else. So be prepared that you can surge, that in an emergency, you're going to be able to provide some services because you're already on the ground, because you already have the partners, you already have the expertise and the people on staff that nobody can fly in to provide. And those are resource-generating opportunities for better or worse. So that would be my advice.
Great, thank you. We're out of time for questions. Jimmy and Karen will both be here if there are other burning questions to come forward. I do want to give each of them 60 seconds for a final bite at the apple in terms of just parting thoughts for the group. Thank you for all of your questions and all, but who wants to lead off?
You should have the last word. No, because you're one of them. I should thank you for what you're doing. And I'm saying that I am an Eastern liberal fringe Jewish secular bureaucrat. I am not your normal constituency. And I've seen, because I lived in Africa for 14 years, because I got involved through no merit or virtue of mine in global health for the last 14 years of my career, you're simply a very valuable component which lots of people like me do not recognize. And you do need to tell your story. I know what you're doing. I know how valuable contribution is. I know there are struggles that you have, but I know there are also opportunities that you miss routinely because you're not thinking about what does the policymaker need to know. You know you're good. How do you spread that message? How do you get onto my agenda? Because I do have an agenda, and I'm not apologizing for that. We need to get things done, and we have rules, and we have money, and we have responsibility and accountability. How can you help those policymakers achieve their agenda? And I think as you think about your organizations and how to grow them and how to meet the needs of the people you're serving, do think about that as part of your organization's mission, because people like myself or my successors in government really can advance our mutual goals.
My last word is to CCIH, that you're doing a wonderful job. Because we don't get opportunities where Christians who are health professionals meet and discuss and have an agenda. For me, I want to encourage CCIH to continue because we are a special group. We are, if you like, we are a minority And this fora also, brings us together as children of God, South and North together. And for our northern partners, you sit here and you hear our struggles, and you are our ambassadors. So in here, there's no divide; we are one. But at the same time, you represent us in the northern hemisphere, where the powers are and where the money is, and we are here to tell the stories, the real stories, and the good thing is that you get to hear our stories. And you translate these stories into action because you mingle with high level, the ambassadors. and we don't have that opportunity, and you create that opportunity. For me, I never thought I would sit. I know we've met somewhere, but I never shared the podium with you. Yeah, so it is this Christian, it's unique. So I want to implore upon CCIH to continue, and I know that you can bring in more voices. Christians tend to be shy, and they did not be shy. We need to speak with a loud voice. We don't have to be shy. We don't have to make excuses. We have a belief, and we need to make others know that we believe in our God. We believe in our Christ. And you bring us together, and this voice is very, very, very important to us from the Southern Hemisphere. Thank you very much.
Thank both of you, Jimmy and Karen.